السلام عليكم ورحمة الله وبركاته. أهلا وسهلا بك وأهلا وسهلا بالسادة الحضور. نورتونا في الويبينار الجديد. أنا بس عايز ألفت النظر إن الدكتور اللي معانا دكتور معانا من الهند، وهو مقيم في دولة الإمارات، وبإذن الله الكلام كله هيبقى باللغة الإنجليزية. طبعا زي ما أنتم عارفين أنا هقفل الشات، وبعد ما نخلص بإذن الله هنفتح الشات تسألوا الدكتور، أو يا إما ترفعوا ايديكم وأنا أعمل لكم أنميوت وتسألوا الدكتور، بس كله بالانجليزي بعد اذنكم. Dear colleagues, it's a great honor to have you tonight with our eminent speaker, Dr. Vishal Pawar from India, a special neurologist at the Garden Specialty Clinic in Dubai. It's a great honor to have you, Dr. Vishal Pawar, in Egypt. It's a great honor to hear from you, and also to have this important, serious topic, which is Vertigo on COVID-19. Let me introduce myself to you. I am Dr. Rami Sherbini, consultant of pediatric and neonatology and pediatric clinical nutrition from Egypt. It's a great honor to have our first webinar with India and with Dubai. I hope you enjoy it, and I hope you will always be interested with our webinar. I will close the chat now and will open it after we finish to ask and to communicate with Dr. Vishal. Welcome, Dr. Vishal.
Good evening, everyone. Thank you, Dr. Rami, for kind introduction and giving me this opportunity to present today. I'm honestly really grateful to you. So good evening, everyone, all those who are attending this webinar. The topic of discussion today is vertigo and COVID-19. So before we start, I'll just tell about some few disclosures. I have nothing to disclose, and I have taken informed consent from the patients if I have shown any images or videos, and I'm sharing my personal experience. There is not enough data. You might find that there is no enough data to back up my findings at some places, but this is like what I have experienced in last 6-7 months, like in last 1 year once the pandemic started, and I have started noticing few patients with vertigo and dizziness who had history of COVID illness. So I clubbed those 5 cases. So initially I will review the literature, and so the today's learning objective is COVID-19 and the vestibular symptoms. So coming to the review of literature, so once we know that COVID-19 affects the respiratory system, but it can also involve the neurological system. And the earliest, the first article came in JAMA Neurology in April 2020. It was from China, the study from Wuhan. Then subsequently, like studies from UK, USA, Sri Lanka, Malaysia, USA, India, and USA and UK collaborated study. So studies started coming from all over the world, showing that COVID-19 also can cause neurological manifestations. So these are the various studies. This is the first initial one. This is another article, and these are the subsequent articles. There are so many studies which started coming up, which mention neurological manifestations. This is one article where they studied the correlation between the dizziness and COVID-19. I'm going to give few details about this article later on. So yeah, so these are the various studies which have come and implicating neurological manifestations because of COVID-19. Now coming to the manifestations, how common they are. Like they are seen in various studies from 25 to 84% of the patients who have had COVID-19 infection. And coming to this particular graph, Here you can see the diagnostics initial, like within 7 days. What happens is initially the viral RNA can be detected, and first thing after viral RNA is IgM antibodies, followed by the IgG antibodies later on. And the clinical presentations, what commonly we see in patients is cough, fever, tiredness, myalgia, and headache, which can start within 7 days or after 7 days also. And within 7 days also other manifestations, neurological manifestations like encephalitis, myelitis, GBS, cerebrovascular disease can be seen. And ADEM, acute disseminated encephalomyelitis, can be seen after 7 days. And the neuropathogenesis of all these manifestations is either direct viral infection or para-infectious. So the para-infectious issues can happen within a week or 10 days, and the post-infectious issues can happen after a week. And there are certain vascular complications also can happen because of COVID-19. So coming to various neurological manifestations of COVID-19, in the acute phase, patients can get ischemic or hemorrhagic stroke. Patient can get cerebral sinus venous thrombosis. Patients can have present with encephalopathy or coma. Patients can develop meningitis, encephalitis, acute disseminated encephalomyelitis, acute transverse myelitis, Guillain-Barré syndrome, and critical illness neuromyopathy because of prolonged admission in the ICU and ventilatory stay. It can also cause rhabdomyolysis, anosmia, dysgeusia, and after recovery from infection, there are many studies which suggest that these patients develop post-COVID symptoms like dizziness, headache, fatigue, brain fog, tingling and numbness, dysgeusia, loss of smell sensation, and myalgias. So these are the symptoms which are seen after the recovery. So this is a diagram which shows that these are the manifestations post-COVID, like headache, dizziness, encephalopathy, cerebrovascular events, demyelination, seizure, and vasculitis. And anosmia, ageusia, and optic nerve involvement can happen, generalized myoclonus, and it can also involve GBS and skeletal muscle. So overall, if you see this diagram, it can affect all the parts of neuraxis, starting from the cerebrum till the nerves and muscle. And this is a diagram which shows that the spectrum of COVID-19 infection is, it involves the manifestations of the SARS and MERS. So there are various manifestations which are overlapping with the other viral infections. And this is one article like where they mentioned that brain fog was seen in 81% of the patients after recovery. Headache was seen in 68%, tingling numbness in 60%, dysgeusia 56%, anosmia 55%, and myalgia 55%, those who recovered from COVID. And many articles have mentioned that these symptoms of headache and dizziness are non-specific symptoms, like non-specific symptoms, headache, dizziness, myalgias, fatigue, and olfactory or taste disturbance. So there is a paucity of literature on specific etiologies, like they are classified, they are mentioned in the literature as if they are like non-specific symptoms. But when I started studying the 5 cases which I came across, I could come to some specific diagnosis, and those cases I'm going to present. Now coming to the pathogenesis of this particular COVID-19 infection, why it can cause neurological manifestations. So if we see the areas in the CNS which are high in ACE2, like there is a receptor called as angiotensin converting enzyme 2 receptor, and these are the areas in the brain which are high in angiotensin converting to enzyme 2 receptors. And this particular SARS-CoV-2 virus has a very high affinity for these these receptors. So these are the areas in the brain where this particular virus can invade because of the presence of these receptors, and it can do it in the two ways. It can either spread hematogenously or it can spread through transneuronal spread through the cribriform plate of ethmoid bone. So these are the two ways in which the virus can spread to the central nervous system, and it can affect various neurological structures. Now coming to this virus, what it does is it has a predilection for these receptors, and it can cause direct infection or it can cause damage because of the immune mediated injury or cytokine storm. And it can cause variety of manifestations, like if it involves the endothelium, it can cause hypercoagulability, acute ischemic stroke, and it can involve the other organs like lungs, heart, and kidneys. But it can involve variety of parts of neuraxis, like central nervous system, peripheral nervous system, autonomic nervous system. And headache and dizziness, it is a very common manifestation which is seen in patients who have recovered, and it can involve the nerves. This is very important point to remember, that it can also involve the autonomic nervous system, and it can cause impaired baroreceptor reflex. It can cause increased sympathetic drive. One of my case I'm going to present, it is related to the increased sympathetic drive in these patients after recovery. Now coming to the neurological manifestations like of headache and dizziness, these are the most common neurological manifestation in several studies, and it could be either because of the direct effect of the infection or due to associated stress, fear, anxiety. And the largest study came from the Wuhan, China. That was the first study of 214 patients, in whom they detected that 25% patients had neurological manifestations, and out of this 17% patients had dizziness. Dizziness as a neurological manifestations of post-COVID, and 13% patients had this headache, and impaired consciousness in 7%. So headache is very common manifestation which is seen, and according to one French study, in that French study they found that headache was reported in 82% of the patients. So the headache incidence ranges from 6% to 82%. The pathophysiology and character may differ according to the phase of COVID-19 illness. In the acute phase also, the patients can have this headache. Even patients can present with headache as a manifestation, as a initial manifestation, and it is related to the flu-like illness, or it could be related to the aggravation of underlying migraine, tension type headache. And later on, in the course of the illness, it could be related to the hypoxia and systemic inflammation. Now, okay. Now coming to, sorry, I will just, okay. Okay. So headache may be a sentinel sign in COVID-19 related meningitis, cerebral venous sinus thrombosis. Now coming to this one study which showed that like the character of headache which was seen in patients was bilateral, it was of severe in intensity, and 62% patients it started within 24 hours of illness. So many patients have headache as an initial manifestation of COVID infection, and nearly 94% cases fulfill the criteria for headache attributed to systemic viral infection. And while migrainous phenotype was reported in 1/4 of the cases, nearly half of the cases had tension type headache. So these are the two common manifestations of the headache. So what they have done is headache manifesting during or after COVID, they have classified it. Either it could be related, like it could be of migrainous type, it could be either tension type headache type. But there are very less studies, or there are no, I would say there are no studies which classify the dizziness. What is the exact root cause of this dizziness? What is causing this dizziness? What are the vestibular disorders which the patient is suffering and which is leading to this dizziness? So there were some patients where the disabling headaches persisted, and this is a table which shows various studies which showed the high incidence of this headache and dizziness. So you can see here 8%. Dizziness was seen in 8%, headache was seen in 11%. Most of the studies have mentioned this presence of headache and dizziness. So coming next here, it was seen in 13% patients who were having headache, 17% dizziness, 9% dizziness, 7% dizziness, 6% headache. So different studies have mentioned different incidence of this headache and dizziness. Now coming to one article which was presented by later from editor on dizziness and COVID-19. So in this particular study, they have mentioned, they have analyzed all the studies which were done with respect to dizziness and the COVID-19. And most of the studies, if you see, they are from China. And these are the total number of cases, and investigation for dizziness were done in very few centers. And the treatment of dizziness was even generic. It was one place where vestibular rehabilitation was done, and the outcome was not assessed. So there are few very we can say there are no studies which tried to classify the diagnosis of these patients with dizziness. Now coming to the clinical characteristics of patients with COVID-19. If we look at the dizziness, the severity of the illness did not differ in patients who had dizziness. Like the incidence of dizziness was equal in patients who had either severe illness or non-severe illness, and the p-value was not significant. So the presence of dizziness is not dependent on the severity of illness. That is one finding. Another finding is dizziness can present as early as the first day of the illness. So it can be the presenting manifestation also of the infection, or it can present even late also up to 30 days. So coming to pathogenesis of dizziness, as I have discussed, the pathogenesis is related to this potential neuroinvasive potential of the virus, and it is related to the just a minute. Okay, I have to disable a 1 second. I'll just disable this. I'm not able to. I'm sorry for this. I'm opening the PowerPoint again. Yeah. So we were here. So apart from we know that this virus has neuroinvasive potential. It has high affinity for angiotensin converting enzyme 2 receptor, and it can cause dizziness due to variety of ways. It can be because of direct invasion, hypoxia, hypercoagulopathy, as well as immune mediated insult can also. So these are the various mechanisms, and there is only one article where they tried to decide what could be the underlying reason for dizziness. It could be because of acute labyrinthitis, vestibular neuritis, acute otitis media, or secondary to stroke following COVID-19. Now I will showcase these my 5 cases. so that what I found in my 5 cases, what were the vestibular diagnosis, we will go into the details. Now coming to case number 1, she 35 years lady, she presented with spinning sensation, and she also had unsteadiness of gait. The spinning sensation used to last for minutes, and the unsteadiness was continuous in nature, and she was suffering from this from last 2 months. And she whole episode, everything started after her COVID infection 2 months ago. And she also complained of headache on a daily basis from last 2 months. The headache was on a daily basis, and it was holocranial pressure sensation in head. It was associated with photophobia, phonophobia. That is, it had migrainous features. She had history of migraine from 11 years, but it was under fair control, and she had typical triggers for migraine. Then in her history, she gave her history of agoraphobia. So agoraphobia is nothing but fear of open places, fear of crowded places, and she gave history of diurnal variation of her symptoms. That is, she feels good in the morning and worse in the evening. And this is her past history. Like in September 2020, she had a history of sudden unprovoked fall and positional vertigo also lasting for 2 to 3 days. And she had dizziness for 1 month, and later on she was all right in between in November, and then when she had this infection, COVID-19 infection, her symptoms flared up again, and she presented with dizziness. Then after taking the detailed history, I do this PHQ-9, which is a screening questionnaire for depression, and GAD-7, which is a screening questionnaire for the anxiety. So I did this questionnaire. So her PHQ-9 score was 15, and the GAD-7 score was 11. So it was going in favor of moderately severe depression, and it was going in favor of moderate anxiety. So this is the patient had associated depression and anxiety. That's what I wanted to convey. Then I did this NIGATA triple PD score, which is a very specific score for the diagnosis of triple PD. The total score was 28, and the visual score was 14. So whenever the visual score is more than 9, as per this article, there is 82% chance sensitivity and 74% specificity for the diagnosis of triple PD, that persistent postural perceptual dizziness, which is a very common cause of chronic vestibular syndrome. In this particular patient, I also did the dizziness handicap inventory, which has around 25 questions, and which categorize the patients into, it helps to know the underlying severity of the dizziness in terms of functional disability, in terms of physical disability, and the psychological disability. So it helps to assess the functional status, physical status, and the psychological state of the patient. So it's a very important, important scoring system for the patients suffering from vestibular disorders. So in this particular patient, it was around 62. Okay, then his neurologic examination was normal. And to summarize, this patient had history of COVID-19 infection. The history is suggestive of vestibular migraine, which presented like even like migrainous positional vertigo initially in September, but later on it presented with it triggered the persistent postural perceptual dizziness, and the patients had associated comorbid anxiety and depression. So I suggested lifestyle modification for this patient. I started the patient on amitriptyline, which is a antidepressant as well as a very good drug for migraine prophylaxis, and it is a good drug for the triple PD also. And I started the patient also on magnesium. The patient took treatment for 1 month and lost to follow-up. And before this presentation, I called the patient, and she gave the history that she was feeling all right. Her symptoms were better after taking the amitriptyline and magnesium. So this is the summary of this patient. So the patient had a history of vestibular migraine and intermittent triple PD symptom. Her symptoms were not established, and she was better after that. And after the infections, her symptoms worsened, and this triple PD became persistent and established, and the migraine attacks were frequent. She was suffering from daily attacks of migraine. Now coming to the case number 2, 45-year gentleman, history of generalized anxiety disorder and depression in the past, but it was very much under control. He suffered COVID illness in February, and then after the 3 days he developed severe headache and dizziness from after 3 days. And the episodes lasted for 1 week. So for 1 week he was suffering from episodes of headache and dizziness. The duration of attacks were from 5 hours to 12 hours, these attacks of headache and dizziness. Okay. Then the headache was holocranial pressure sensation. It was severe in intensity. It was associated with phonophobia, photophobia, and patient had 10 episodes per month from last 2 months. And so there are few historical points which go in favor of vestibular migraine. These are history of motion sickness in childhood is a very common history which is found in patients who suffer from vestibular migraine. Patient also had pressure sensation in both the ears, and reduced concentration and focus is a very common symptom of vestibular migraine. So it is similar to the toppings of the pizza, and we see these toppings in very commonly in patients with vestibular migraine. So there was no hearing loss and tinnitus, no agoraphobia, no diurnal fluctuations. And the current symptoms, like after a period of 2 months, the patient was dizzy, especially in the night time, and sleeplessness, restlessness. Patient was getting panic attacks in the night time. And this was the dizziness handicap inventory, like around 22. The suffering was dizziness handicap inventory indicates the suffering of the patient, and this was the score, like GAD-7 score was 13 indicating moderate anxiety, and the PHQ-9 score was 15 indicating moderately severe depression. So these were the scores, like both were indicating like moderate anxiety and moderate depression. And now coming to so the summary of this patient had baseline anxiety and depression. Then patient underwent this COVID illness. Then patient developed this vestibular migraine. Anxiety and depression worsened, and lately the patient presented with repeated panic attacks with dizziness in the night time and sleeplessness. So if we look at the literature on psychiatric disorders and dizziness, if a person who is suffering from psychiatric disorder suffers a vestibular disorder, what happens is the psychiatric symptoms worsen. They worsen in severity, the psychiatric symptoms increase in severity, and the psychiatric disorder starts manifesting as dizziness. So this is a very important thing to be seen, and this patient had underlying anxiety, and that aggravated because of this COVID illness, plus the patient started manifesting with dizziness, and because of the vestibular migraine initially, and later on the psychiatric symptoms themselves started causing the dizziness. So treatment in this patient, treatment offered was lifestyle modification. Patient was started on amitriptyline, Concor, that is bisoprolol, magnesium. Patient was started on vestibular rehabilitation. Unfortunately, the patient was not convinced with the treatment for first initial 2 months of his follow-up. and the patient developed worsening of the symptoms of migraine in the form of persistent visual aura without infarction. Without getting any infarct on the MRI, brain patient was continuously feeling blurred vision, and there were no associated episodes of headache, but the patient was continuously having those visual symptoms, and he didn't receive any treatment for few months. But later on he is now convinced, and he started the amitriptyline and bisoprolol and magnesium, and he is like doing well. Now coming to the case 3. Case 3, the 45 years lady, she had COVID-19 illness in December 2020. She presented with spinning, vertigo, recurrent attacks of headache. She feels like walking on water, and duration of the spinning attacks were 1 minute, and they were positionally triggered attacks on getting up and lying down. She had 3 similar attacks of vertigo in the past, in last 9 years. The first episode was 9 years ago, the second episode was 5 years ago, and the third episode was 3 years ago. So these were the episodes of like her headache, this vertigo, and this is the history for the headache. So she had also his associated history of headache, which had migrainous features. If you look at all the features which are going in favor of migraine, but there were no triple PD symptoms, no agoraphobia. And coming to positional testing, testing didn't show any localizing findings like classical of BPPV. And her PHQ 9 and was 9, and GAD 7 was 3. So patient had mild depression, and very like there was no anxiety, and the dizziness handicap inventory was 56. And the Nigeta triple PD score was 27, and visual score was 6. So the patient was having a trait towards developing the triple PD. So this is one other point I would like to highlight is, if the patients have underlying triple PD trait, they are more predisposed to develop this full-blown symptoms of triple PD. So it's very important to treat their underlying vestibular disorder so that they don't develop the triple PD symptoms. To summarize, this patient had history of COVID-19, vestibular migraine, which presented as migrainous positional vertigo, and triple PD trait the patient had. Patient had some features like we like triple PD, but it was not qualifying the diagnostic criteria, and very mild depression and no anxiety. So okay, just a minute. Now coming to like this patient also was reluctant to start amitriptyline. Patient was suggested lifestyle modification and magnesium, and I took follow-up for this presentation, and patient is doing well in the 3-month follow-up. So to summarize, this patient had 3 episodes of vestibular symptoms in the past, which were like vestibular migraine. I feel that patient had underlying vestibular migraine, but after suffering from the illness, the vestibular migraine increased in severity, and the patient was developing triple PD symptoms. But because slowly the symptoms reduced in severity, and in 3 months the patient became all right. Now coming to the case number 4, 29 years gentleman, unsteadiness lasting for seconds from 1 month. The trigger for the unsteadiness were walking at a natural pace, quick head movements. These were the triggers for the symptoms. Okay. Now coming to the history of headache in the same patient, the patient had holocranial headache, which was non-throbbing, moderately severe. It was increased by movement. It was daily from 1 month, and there were typical migrainous triggers. So patient had associated worsening of migraine, and along with that he had symptoms of one disorder like reduced concentration, fatigue, memory loss, tremors, sudden fear while driving, and there was no tinnitus, ear pain, or fullness. So if we look at the diagnostic criteria for chronic fatigue syndrome, the patient was satisfying the diagnostic criteria. Like patient had a history of headaches, like muscle pain, malaise, fatigue, and unrefreshing sleep, and significant impairment in the memory and concentration. So these all features are in favor of diagnosis of chronic fatigue syndrome. And I also in the past history, I have seen in this patient that patient had history of head injury in 2012, and dizziness. After the head injury, many patients feel chronic dizziness, and one of the very common cause of chronic dizziness in this patient is presence of triple PD, that persistent postural perceptual dizziness in patients after the head injury. Patient also had history of agoraphobia in 2012 and history of post-traumatic stress disorder and panic attacks that time. So patient had similar history in the past, and currently his GAD 7 was 11 and PHQ 9 was 17. So the depression patient also had depression that was moderately severe, and patient also had moderate anxiety. I did the dizziness handicap inventory score, which indicates the disability because of the dizziness. It was around 28. To summarize, this patient had history of COVID infection, and the patient doesn't qualify the definite vestibular migraine criteria, but the patient follows the probable vestibular migraine criteria, and the patient had his symptoms suggestive of chronic fatigue syndrome associated with depression and anxiety. So the patient was started on amitriptyline, started on lifestyle modification and magnesium. Patient was referred to a psychiatrist. When I was taking the follow-up, the patient didn't start any of these medications which I prescribed, and slowly he recovered out of his illness, and he is doing well in his 3 months follow-up. So to summarize, this patient had unsteadiness for 4 years with agoraphobia after head injury in 2012. So this patient had history of some vestibular illness in the past, but after the COVID infection, again the symptoms flared up. Like the patient had this vestibular migraine, chronic fatigue syndrome, depression and anxiety, and which recovered over a period of time. In 3 months time, without any specific intervention, slowly the patient recovered. So there are patients who recover without any intervention, and there are patients who, despite of intervention, they take a lot of time to recover. So that's the spectrum which I have seen. And coming to the last case number 5, 66 years lady, history of COVID infection in January 21, sorry, and this patient had imbalance from last 2 months and continuous lightheadedness with momentary flares. She wakes up from sleep with these symptoms, and she was having these symptoms on turning to either side and getting up. And she was feeling the worsening of symptoms while watching the TV. The symptoms were again more in the night time. So this is another patient where the symptoms were more in the night time and not in the daytime. And the associated symptoms like sleeplessness and headache, which was similar to migrainous variety, like mild and emotional stress, excessive use of electronic devices was one of the trigger. And the dizziness handicap inventory was not very high, it was 8. And the depression score was it was not so much, like it was around, patient didn't have any severe anxiety or depression. And then I did positional testing for this patient, and which showed patient had upbeating torsional nystagmus in the right distal pike testing, and that was diagnostic of right posterior canal BPPV. I did a please maneuver. In the follow-up, the patient's spinning improved, but there was no improvement in the lightheadedness and lightheadedness and little feeling of imbalance. And I was of the opinion, second visit, that the patient has developed this post-BPPV dizziness, which is very common after successful canalith repositioning. But patient again came after a week in third visit. Then I thought of checking her blood pressure because patient was not feeling well. So I thought of doing the postural blood pressure and pulse measurements. And these are the findings. If you look at the pulse, pulse increased from 77 to 110, and it remained high in 3 minutes standing and 5 minutes standing without any drop in blood pressure. There was no drop in blood pressure with associated slight dizziness. So these were the findings, and this is one of my patients. So if we look at this patient, his heart rate went up to 125 after lying down. And if you look at the initial heart rate was 85, and the patient's heart rate went to 125 after standing up. And it remained sustained, and the patient had a continuous feeling of lightheadedness. So this is a case of postural orthostatic tachycardia syndrome. And this patient I have seen 2 years ago. Just for demonstration I showed this video, but the particular lady which I presented also had similar tachycardia in her presentation. Sorry, yeah, I'll go forward. Next slide. Yeah. So in this particular patient, the patient had, after standing up, there was sudden increase in the heart rate. The heart rate increased from this level to this level, and the blood pressure remained static, like there was no associated fall in blood pressure. So this qualifies the diagnostic criteria for postural orthostatic tachycardia syndrome, in which there is sustained heart rate increase of more than 30 beats per minute, or the heart rate increases more than the baseline, like more than 120 beats per minute, and within 10 minutes of standing, and which remains sustained, and there is no associated fall in blood pressure. And it is a common cause of orthostatic dizziness. The age of presentation is 15 to 50, and the females are more commonly affected, and there are various causes for this. The most common, one of the common cause is hyperadrenergic state, which is very common post COVID-19, hypovolemia. And so these are the my speculation is that patients with COVID-19 are prone to have this hyperadrenergic state, and which can lead to presence of these spots, postural orthostatic tachycardia syndrome, in this patient. Of course, I have only one patient. Post-COVID, she developed this particular illness. So maybe subsequent studies will help us to know more about this particular entity. So in her fourth visit, she was complaining of dizziness more on lying down, wakes up with panic attack, and BP readings were improving slowly. So to summarize, patient had history of COVID infection, initial visit, BPPV, which was corrected, but still the symptoms were not improving. So patient, I thought of this POTS diagnosis, that is postural orthostatic tachycardia syndrome, and probably she has vestibular migraine also, and she was also suffering from this insomnia and post-traumatic stress disorder. Because of this trauma of this illness, COVID-19 illness, she was getting these panic attacks, especially in the night time. So to summarize this history of COVID infection, and initially there was I treated her like BPPV. Second visit I thought of post BPPV dizziness, but when I checked the blood pressure readings, she was actually having postural orthostatic tachycardia syndrome also, and she is currently suffering from insomnia, post-traumatic stress disorder, and the POTS symptoms are improving. So these are my 5 cases where these are the various age groups of these patients, which range from 29 years to 68 years, and none of these patients needed hospitalization for their COVID-19 symptoms. They didn't need hospitalization or oxygenation, and the history was ranging from 30 days, that is 1 month, to 2.5 months. And 2 of the patients developed the symptoms after COVID, and 3 of the other symptoms had this vestibular illness before the onset of COVID, and but it was intermittent in nature, but it became persistent after COVID infection. And the various diagnosis, variety of diagnosis I could make in this patient, the most common being the vestibular migraine, which was seen in 4 patients, and the other diagnosis, which like triple PD in 1 patient and triple PD trait in another. Depression, anxiety was also common in these patients, and BPPV in 1 patient, and postural orthostatic tachycardia also was seen in 1 patient. So in treatment, it depends on what is the diagnosis. Accordingly, the patient needs treatment, and the follow-up. Some patients took without receiving any treatment also the patients recovered. Those were the 1 and 2. These are the 2 patients without any specific interventions. Patient had improvement, but despite of the treatment, there were 2 patients where there were worsening of symptoms, and so it is a spectrum. Like patients can present with different severity of illness after the COVID infection. So that was my presentation. With this I would like to thank Dr. Rami and for giving me this opportunity to present today. I'm really very thankful to him, and it's a very relevant topic for the current discussion, because everywhere all over the world, this COVID-19 pandemic has affected so many people, and those who have recovered out of the illness, they are suffering from very variety of symptoms and brain fog, neurological symptoms. So awareness of these symptoms and awareness of these disorders can help us to diagnose them and treat them properly. Thank you so much. Over to you, Dr. Rami.
Thank you, Dr. Vishal, for excellent presentation. Neurology, one of the specialists which I found always very difficult, but after your lecture, I liked it so much, and it became very interesting to me. Thanks for simple and brief presentation. I'm extremely proud to have you as my first speaker from India, and I hope it will not be the last one. It will be the first and not the last, because I know you are an excellent speaker. Your presentation was marvelous. Thank you, and thanks for the attendance from Egypt and India and Iraq. And I will open questions, but I want to start with my question. You say electronic devices triggers migraine. Do you see that with COVID-19 or generally, even without COVID-19?
Even without COVID-19, this particular finding, for example, from last 4 months, I started maintaining a data of triggers of patients with migraine in general, not related to COVID-19. And I have found that this particular trigger of electronic devices was seen in almost 50% of the patients. Yeah, I could collect the data of 110 patients, out of which 55 patients, that is almost 50% patients, had history of excessive usage of electronic devices as one of the trigger for the migraine. So in general, it is basically because of this pandemic situation, because of lack of socialization, people are using, and because of everything has become online, the work is online, schooling is online. I have seen many school teachers who are suffering from terrible vestibular migraine or even migraine in general because of excessive usage of electronic devices. So it is one of the common trigger which is seen in pure migraine as well as vestibular migraine patients, and it was also seen in patients who had COVID infection. It was one of the trigger.
Okay, thank you, Dr. Vishal. My second question, if one have a migraine headache and it's repeated about every 2 to 3 months, 2 to 3 months repetition of migraine, and every time it is severe, at the left side of the head, accompanied with blurring of vision, and after a few days it disappears. He took no medication. Is this a symptom or a sign of COVID-19 infection?
See, if the migraine is happening occasionally, like was there any history of migraine before the COVID infection, or this was started only after the COVID infection?
There is a past history of migraine, but not so much frequent. One every 6 months, one every year. But this time, he told me the migraine frequency become more frequent. The migraine became more frequent, about every 2 months, and every time it came, it is very severe, and it is the same side, is the left side of the head, and it comes with blurring of vision. And after a few days, it disappears. The same symptoms stated by the patient. Every 2 months, severe with blurring of vision, and disappears few days later.
This can be seen because worldwide there are I presented few studies, and headache was very commonly seen in patients who have recovered from COVID, and those patients who have had history of migraine or without even history of migraine, there can be increase in the severity and frequency of migraine. It can be seen, and the patient which you are mentioning, definitely yes, it could be related to the COVID-19 and post-COVID syndrome. So it's very important that in these patients we have to teach them the lifestyle modification measures and start the prophylactic medications. And yes, it can happen after infections. I have seen some patients coming with even after vaccination also. Sometimes some patients I have seen developing attacks of migraine, increase in the severity of and frequency of migraine.
Thank you so much, Dr. Vishal. Now I open the chat. Everyone who wants to ask Dr. Vishal any question, he can write in the chat or raise his hand, and we'll make him talk to him verbally. And I ask all the attendees to talk in English, please. I will thank you, Dr. Fadil. Please, anyone who wants to ask Dr. Vishal any question, write in the chat or raise your hand to talk to him. Thank you. All of them are happy to having you with us, and they say that your lecture was excellent. And as always, Dr. Vishal, you are excellent and more than excellent. Please, anyone who wants to ask Dr. Vishal any question about the Vertigo and COVID-19, please write in the chat or raise your hand to talk to him. Yes, I will start. Hi. Assalamu alaikum.
Hello, salam.
Please introduce yourself.
Yeah, I'm able to hear you. Go ahead.
Yes, what's your name? What's your nationality?
Hi.
Yeah.
Can you hear me?
Yes, I hear you well.
Okay, I am Dr. Rehat Tantawi, consultant from Egypt.
Yes, you are from Egypt.
Yes.
Yes,
I
you are
just want to
welcome.
ask. Thanks a lot. I just want to ask about sensorineural hearing loss as a presentation of COVID. I have many patients with sudden sensorineural hearing loss. A few days after getting got the infection of COVID. Some of them improved and some is not improved. They are still for a few months. Is there any guide for further management or drugs to be received?
Thank you.
Thank you.
Yeah, thank you for your question. It was mainly regarding the sensorineural hearing loss. Honestly, I being a neurologist, I'm not a right person to answer this question because the audiovestibular specialist or ENT surgeons can answer this question well. If there is anyone in the audience, maybe they can share their experience. But as a neurologist, I didn't see any patient with sensorineural hearing loss. But I have heard that that is also one of the common complication of COVID-19.
Okay, thank you, Dr. Vijay. Dr. Abdesalam from Egypt want to ask, can vaccination prevent reinfection by COVID-19?
Yes, like vaccination, see, to a large extent it can prevent infection, but the infection can still happen, like still patients can present with infection. But the vaccination, the most important advantage of vaccination is it definitely prevents the death. Most of the vaccines, they are they prevent the severe illness and the death because of COVID-19. But infections can happen, like infections still can happen, and especially up to 2 to 3 weeks after the second dose, the infections can happen, and even some patients can have severe illness up to 2 or 3 weeks after the second dose. So the immunity actually builds up after the second dose after 2 to 3 weeks. Therefore, we have to actually analyze the population who develops infection after the 2 weeks of second dose, and those population will definitely the severity of infection will be less, and the death we can prevent. But before that, some patients can develop infections, and it can be serious also. I have seen some patients like after the first dose also, within 15 days, those who developed infection, some patients succumb to the COVID-19. So the actual immunity develops after 2 weeks of the second dose.
Thank you, doctor. You mean that vaccine decline complication or the poor outcome of COVID-19, but reinfection can happen?
Yeah, infections can still happen after even both the dosages, but it is a good tool to prevent severity of infection and the death. Basically, so infection, even if it happens, what is more important is saving the lives is important. Patients can get infected, but if we can save the lives that and severe infections, that is very important.
Thank you. Dr. Absalam said that he is from Libya, not from Egypt. Welcome from Libya, welcome from Egypt, and welcome from any country. نورتنا دكتور عبد السلام، بريك تشرفنا في كل الويبينارز اللي جايه ان شاء الله. طيب دلوقتي اللي عايز يسال اي سؤال، anyone want to ask Dr. Vijay any questions, please raise your hand or write in the chat. If anyone please want to ask Dr. Vijay any question, raise your hand to talk to Dr. Vijay or write in the chat. I want to ask you a question, Dr. Vijay. What about mucormycosis, which suddenly arises in the few days ago, even in India or any other country? What do you think about mucormycosis? What is the reason of its sudden appearance? What is the danger? Is mortality rate? and it's linked to COVID-19. I know you are a neurologist and not microbiologist, but if you know anything about mucormycosis, how it appears suddenly in India, and its mortality rate.
See, it's very unfortunate that this COVID-19 patients in India, many patients are suffering from this deadly fungal infection. And one of the main reasons for patients suffering from this mucormycosis is because of injudicious use of steroids. So many patients are receiving steroids injudiciously, and even patients with mild infections are given steroids for longer duration of time. That is the one reason. First reason is injudicious use of steroids. The second reason is because of underlying low immunity, like in patients with diabetes, they are more prone to develop this complication. Third is the use of mask for longer duration of time, use of same mask. Many people are using the one mask for even 1 week, 10 days without, if they are using a cloth mask, they are not washing it. And because of usage of mask repeatedly, the same mask, there is growth of fungus, and they are more prone to develop this complication. Another very important finding which showed that this water which is used in the ventilators, that for the ventilatory support, this water is infected with some places. It was found that it was infected with the fungus. So there are a variety of reasons which are leading to this increase in the number of mucormycosis cases. And these are the variety of postulated mechanism by which it happens, and the mortality rate is very high. Exactly I don't know, but almost the mortality rate is 80 to 90% patients are succumbing to infection. It is very important to pick them early and treat them surgically and remove the infection, start them on antifungal medications. Thank you.
Thank you. I think, as they said, it is not transmissible from human to human. I hear that from many lectures, that it cannot be transmitted from human to human, and no to human transmission. And instead of that, it's a mortality. They say, the last article I read, they say that it is 60% mortality rate, and you say that from 80 to 90. Overdose and abuse of antibiotics and steroid is, as you said, is the most common cause, especially severe cases of COVID-19, which take this regimen of treatment for many weeks, which decreases their immunity, and mucormycosis is an opportunistic infection, which takes place when immunity is affected. I know that fungal infection treatment is very difficult and takes a long of time, and I hope there will be a good treatment and a good precaution. And as you said, Dr. Vishal, this is a common mistake of use of the same mask for a long period of time. This is a severe mistake, and also the main cause of spread of this fungus. Dr. Ali Hussein Hassan, his question is that, is there any probability of getting vertigo after receiving COVID-19 vaccine?
Yeah, for example, I will share one of my case, but it's very difficult to postulate it. One of the patient who underwent COVID-19 vaccination, some patients are coming up with vertigo because of vestibular migraine, underlying increase in the severity of migraine and dizziness. So one patient I have seen where the patient developed vestibular neuronitis after a week of vaccination. So, but it is very difficult to cause-effect relationship between the vaccine. Maybe the patient was going to get vestibular neuronitis, but because the patient got vaccinated, we are attributing to it. So further studies, further research will help us to know whether really the COVID-19 vaccination can lead to vestibular disorders. But currently the evidence is very limited regarding this particular area.
Thank you, Dr. Vijay. Dr. Abdel Salam from Libya. Which type of vaccination is suitable for a person who is suffering from chronic disease?
See, again, it's a very tricky question. It depends on which vaccine is available in your country. The options which are available, they will decide. But for example, in UAE, there are options available where Pfizer vaccination, Sinopharm, and even other vaccinations are also available. So my advice to many patients who were coming to me and asking me which vaccination they should take. So my advice was whichever vaccine they get first appointment, they should go ahead, because vaccines, all the vaccines were shown that they reduce the incidence of severe infections and the mortality. So it depends on which vaccine is available in your country, and whichever is available, that is the only choice you have, to go for vaccination. And I would suggest to go ahead rather than going into the percentages. It's very important to receive the vaccination in any of the form, because most of the vaccines have very good efficacy and to prevent the death.
Yes, thank you, Dr. Vijay. I will unmute one of the speakers, one of the attendants, sorry, to ask you a question. They asked me many times. Fadla, Doctor.
Hi, I'm Dr. Ihab Tantawi from Egypt. I just want to ask about the management of cacosmia post-COVID. Many patients come to me with anosmia, and the anosmia improves slightly, but they develop what's called cacosmia. They get to smell bad odor. Is there any route for Gapten in this case, or any further management?
Thank you, sir. Thank you for your question. But honestly, I won't be able to answer, because being a neurologist, cacosmia, I think audiovestibular physician or basically a ENT surgeon, otolaryngologist, would be able to answer this question properly. Or I will read about it and maybe get back to you in the forum. Our forum, I will answer this question.
Thank you, Dr. Vijay. Dr. Warfan Ali, why some people warning us from vaccination? Are they dangerous?
I didn't get the question. I will read it. So why some people warning us from vaccination? Are they dangerous? No, there are certain I don't see the vaccinations. There are certain implications of getting vaccinated. For example, it was found that some people are susceptible to side effects, but that is true about the incidence of clots or incidence of mortality is far less as compared to getting infected and the complications of COVID. So it's very important to not believe on these rumors and to get vaccinated. And there are at least there are no major issues associated with vaccination. Most of the vaccinations are relatively safe, and it depends on which vaccine you are talking about. But most of the vaccines are tested in trials, and majority of people are undergoing vaccination. Lakhs and crores of people have got vaccinated. If there are any major issues, it should have come up. But there are isolated incidences of some people who are susceptible to side effects of the vaccination, but that number is very less. And as I have said repeatedly, it is very important to get vaccinated, because it prevents the serious infections and mortality. And yeah.
Thank you, Dr. Vijay. I want just to ask an additional question, if you allow me. Convulsion.
Yeah.
Do you see any patient who suffered from convulsion due to COVID-19?
See, I work in a setup where, like, I'm working in a clinic setup. So we do have one hospital where my colleagues are taking care of, and they have seen cases where the patients presented with convulsions because of encephalitis. Patients presented with convulsions due to COVID-19 because of acute stroke, intracranial bleeding, intracerebral hemorrhage. So yes, it can cause, but the percentage of patients who present with convulsions is very less than 1% as compared to the other symptoms like headache and dizziness or other manifestations.
Thank you, Dr. Vijay, for your answer. Dr. D.V. Brasen, I will unmute you, doctor, to introduce yourself. Raise your hand if
Yeah.
to see you.
Dr. Devi Prasan, yeah, his question is, can COVID-19 cause, one second, I lost the question, yeah, cause vestibular neuritis? It's a very difficult question to answer because...
Dr. Devi, you can talk now if you wish.
Yes, hello, sir. I'm Dr. Devi Prasad.
Yes, from which country?
I am from India.
Yeah, hi. Hi, nice to meet you, and nice to see you and to have you in Egypt. You are welcome. You can ask your question.
Yes. Vishal, sir.
Yeah, tell me, sir.
Hello, Vishal, sir, can you hear me?
Yes,
we can hear
you.
Yes.
And I, yeah.
Has vestibular neuritis become
see,
I think there is
become common after COVID-19 infection.
Yeah.
Repeat your question.
We are seeing many cases of headache after infection. How to treat that? Headache after COVID infection.
Yeah, coming to the first question of vestibular neuritis. See, in last 4-5 months, whatever vestibular neuritis cases I have seen, only one patient, like there was history of vaccination 1 week ago. Apart from that, I didn't see any patient after infection. Maybe the number of cases here is very less. So I am not in a position exactly to because if you see the number of cases in UAE in last 1.5 years, the maximum number of cases have never gone above 4,000. And we being a small country, and despite of that, if we see the proportion of cases, it has not gone beyond 4,000. So the number of cases is less, so I won't be able to I have not seen in my experience, I didn't see any cases of vestibular neuritis after COVID-19 infection. That is one point. Second is about your second question, how to manage the headache post COVID-19. So basically, it's very important to see whether that headache fits into diagnostic criteria of migraine or tension type headache, or it is a non-specific headache which is related to infection, systemic viral infection. So if patient is fitting the criteria for migraine, and I feel that most of these patients have migraine post COVID-19, and it's very important to teach them the lifestyle modification, to ask them to avoid the triggers for the migraine, and to initiate them on prophylactic medications like propranolol or amitriptyline or flunarizine. So if the patients receive the prophylactic medication, we can take care of the headache. If the headaches are occasional, less than 3 or 2 episodes, then they can be managed by SOS painkillers. But if the headaches are disabling and more than 3 episodes per month, then it's important to initiate the prophylactic medication.
Thank you, Dr. Vishal, for your answer. And thank you, Doctor, from India. It's a great honor to have you from India. Welcome from Arab Republic of Egypt to India. Nice to have you. Anyone who wants to ask Dr. Vishal, you can write in the chat or raise his hand to talk to him. Any question? Any last question? Okay, thank you. Thank you all. Thank you all, Dr. Vishal Pawar. I'm very proud and I'm very glad to have you in Egypt. Thank you so much. And I want to mention something. All of you are invited to our next webinar, which will be about sample size estimation. After 4 days, on 10th of June, our eminent professor, Dr. Magdi Ibrahim, from Cairo University, Kasraini, will come to us and will talk about sample size estimation. All of you are invited, especially you, Dr. Vishal Pawar. I hope to see you. And yes, you are joined our Facebook group, and also you joined our WhatsApp group, and you will be informed with the direct link of the webinar. I hope to see you there. I will be proud to have you in all my webinars. And also I want to make a series of webinars about neurology with you. I will be proud of that. Also, if you wish, I want to make a course about EEG and ENG, if you wish, and if you have time. I thank so much. I am very proud to start my webinar with India with Dr. Vishal Pawar, and also I hope it will be my last webinar with India. I know you are eminent doctor, you are excellent doctor, you are clever doctor. I always listen to your lectures, even from neurology or cardiology or pediatrician. Nice to have you in Egypt. Thank you so much. Thank you for all the attendees. Thank you so much, Dr. Vishal Pawar, and I hope to see you again. Thank you so much, and take care of yourself.
Thank you. Thank you.
Thank you. شكرا للسادة الحضور. Thank you for the attendees. إن شاء الله تشرفونا في الويبينار الجاي وأسعدتونا، ويا رب تكونوا استفدتوا من الدكتور. طبعا أنا عارف الموضوع أدفانسد شوية نيرولوجي، مش كل الناس انترستد فيه، بس يا رب يكون الويبينار عجبكم. بصراحة الدكتور فيجل باور كان رائع وكان شرحه سو سيمبل، بصراحة عجبني جدا يعني. شكرا لكم كلكم، وإن شاء الله نتقابل على خير. زي ما قال الدكتور فيجل باور قال، you have to get vaccinated because vaccines stop the complication or decrease the complication and decrease the mortality rate. Thank you so much. كل سنة وانتم طيبين. شكرا للحضور من دول عربية ومن ليبيا ومن مصر ومن العراق ومن الجزائر، وشكرا طبعا للناس اللي حضروا من مصر. Thank you so much for the attendees from India. I was proud to have you in Egypt. Thank you so much. أيوة، المحاضرة مسجلة وهتتذاع على القناة بتاعتنا إن شاء الله في خلال يوم أو يومين، وإن شاء الله تسمعوها وتستفيدوا منها. أنا دلوقتي هنزل لكم 3 لينك هتستفيدوا منهم جدا إن شاء الله.